morning. It's Dr. John Bennett broadcasting from Miami Beach. We have the honor today of broadcasting grand rounds from Jordan with Dr. Ibrahim Sabaya, a neurosurgeon educator that's been doing these, not webcasts, but doing educational seminars for 27 years. And luckily, we got him to try new technology to reach more followers. And rather than stumble through all the introductions, why don't we just go straight away to the presentation, Dr. Sabaya, and it's all yours, and thank you.
Thank you very much indeed. I would say good evening, good morning, wherever you are. Greetings from Jordan, where I'm stationed now. And this is the Farah Medical Campus where I work in Amman, Jordan. As I always start by stating what is the presentation about today. It's pineal locus tumors. And as usual, we'll go through clinical, radiological, operative, and pathological correlation. Before we do that, I'll just present to you some of the features of my beautiful country, Jordan. This is the city of Jerash, the only intact Roman city outside Italy, outside Rome. So it is really well intact city from the times of Roman, 7,500 BC. And this is the main center of the old Roman city. This is the picture at night where people visit. And this is the circle there with the columns. As you can see, the main street in the old city of Jerash, the Roman city. This is the time of spring. And this is the main auditorium where festivals and ceremonies would take place. And in Jerash, since 1980, we have the Jerash Festival. So about 40 years now, with this festival going on, attracting hundreds of thousands of people from the Arab world and surrounding countries, because it's really unique and special. All sorts of entertainers, singers, musicals are performed here. So imagine sitting among the ancient ruins of Jerash, listening to Bolshoi opera, listening to opera singing, etc. So it's a beautiful city of Jerash. So Jerash Festival. I don't know whether we have it this year or not because of the coronavirus, because it's usually July, August. Hopefully it will be open by then. So back to our presentation, pineal locus tumors. And I have to go through the anatomy of pineal gland. I thought, and I always still thinking, that people do not understand well, especially the residents, the pineal gland physiology and anatomy. Pineal gland, as you can see, this is a small gland sitting at the back of the brainstem. This is the superior and inferior colliculus on one side, superior colliculus, inferior colliculus on one side, pulvinar of thalamus, and this is the back of the third ventricle. So here you are sitting there, and this is pulvinar, this is the pineal gland, the superior colliculus. And if you go above it, then you can see the whole of the cavity of the third ventricle with the massa intermedia there. Why is it called pineal? Because it looks like pine tree. So that's the name where it came from. So that's the pineal gland. As such, the superior colliculi here and the pineal gland there. Again, here, if you are looking from behind, from posterior view, you can see the pineal there with the superior and inferior colliculi. It's a very critical area where this beautiful gland is situated. So the tent, the pulvinar of the thalamus, the parahippocampal gyrus, the temporal lobe, and here are the veins, the vein of Galen, and so on, giving the Vermean vein. Closer look at how it looks from underneath the tentorium, and here is the parahippocampal gyrus. So this is the gland, superior colliculus, inferior colliculus. Here is the sulcus, the mesencephalic cerebellar sulcus, and then here comes the fourth nerve from the back of the midbrain. Again, you can see this little gland sitting, and this is the cavity of the third ventricle. Same thing in here. Why am I showing this? Because we will see this through the video. So if we don't understand anatomy, we will miss the pictures that we are going to see, still pictures and the video running. So this is the pineal gland looking like a pine tree. And this is the so-called the crus. There is one crus on one side, another crus on the other side. Sagittal view. This is the corpus callosum, the splenium, and you can see that we are here. Again, cut through the midline. Then you can see the quadrigeminal plate of the midbrain, the tectum of the midbrain, and here is the posterior commissure, and then we have the pineal gland, and there is a recess that's going into the body of the pineal gland, and above it is the appennular commissure. So anterior commissure is here at the upper end of the lamina terminalis, and posterior commissure is here, appennular commissure is here. Same thing here, tectal plate, superior inferior colliculus, posterior commissure, and that's the gland, and this is the splenium. And here, through this small space, comes the internal cerebral veins to join together with the other veins, vein of Rosenthal, to form vein of Galen. Same picture, splenium of the corpus callosum, the pineal gland, the internal cerebral vein coming this way to form, with the other veins, the greater vein of Galen. Same picture, internal cerebral veins coming from the roof of the third ventricle to form. So the pineal gland is tucked here between this structure here, this structure here, and this structure here. Splenium, internal cerebral veins, joined with other veins to form vein of Galen, which will form here the straight sinus. Closer look again. This is the posterior commissure, this is the pineal gland, and this is the pineal recess, and this is the appennular commissure. One has to be familiar with this anatomy if one wants to operate in this area. So, what is the pineal gland? What's the physiology? What's the function of the pineal? It's an endocrine gland, and it secretes melatonin, which regulates our sleep. So melatonin is involved in the sleep-wake cycle that we experience. The melatonin is secreted at night so that it will prepare us to sleep. Once the daylight comes, the secretion would decrease so that we can get up. So melatonin secretion is at night. Early morning, it decreases the secretion. So if you are traveling in an aeroplane, whether east or west, then you are sort of having the lights in the aeroplane on, then the melatonin would think that this is still daytime, so decreased secretion. That's why you get the jet lag, because melatonin is not working. And the pineal gland shares this function with the suprachiasmatic nucleus of the hypothalamus. Both are related to this sleep-wake cycle. So melatonin is our sleep hormone. And as I said, whether you receive a light through daylight, or your eyes are closed, or there is dim light, there is closed light, black light, then the communication between the anterior commissure and the posterior commissure and the pineal gland would cause the secretion of melatonin, as I said, at night. So this is the clock. At 6 a.m., when we want to wake up, the melatonin secretion stops so that we'll feel that we are energetic and get up, while starting sort of 6 p.m. and beyond that, 9, 10, 11, melatonin secretion starts, and then you feel the desire to sleep. As I said, this is shared with the suprachiasmatic nucleus of the hypothalamus. With the connection between suprachiasmatic nucleus, the mammillary body goes to the anterior commissure, and then from the anterior commissure goes through the fornix to the area of the pineal gland. Again, here, this tentorium anatomy is important because the pineal gland is resting here, so we have to understand this anatomy, and therefore we have to understand the veins that are there. And I've always been struck that most of the neurosurgical residents, they have no idea about the venous anatomy, as if it does not exist, as if the veins are not important. It is very important, especially in this area. So this is the superior sagittal sinus taking all these superficial veins, the sort of cortical superficial venous drainage going to the superior sagittal sinus, and then we have the inferior sagittal sinus in the inferior edge of the tentorium. And here, the thalamostriate vein joins with the anterior septal vein to form the internal cerebral vein. And the internal cerebral vein will be joined by vein of Rosenthal to form the vein of Galen. Here, the superficial middle cerebral vein would drain into sphenoparietal sinus and then into the cavernous sinus. So it's important anatomy, and this can be demonstrated in this venogram. This is one of my patients, and you can see the anatomy that we just described, the internal cerebral veins and the venous drainage into the cavernous sinus, inferior petrosal and superior petrosal sinus. This is vein of Labey. If you look at the vein of Rosenthal, which is an important a component of forming the vein of Galen, then it will start here from the anterior cerebral vein, joined with the deep middle cerebral vein to form this trunk here. So anterior cerebral vein, middle cerebral vein, joined by this peduncular vein, going around the brainstem, receiving these veins from the hippocampus and parahippocampus, receiving also veins from the medial temporal area, and then joined by the internal occipital vein to form, as I said, with the internal cerebral vein, a vein of Galen. This is a beautiful demonstration in Yazarjil book, and I will refer to this point in a big way. It's no good that people read from little handbooks of neurosurgery thinking that this is what they need to learn. I mean, every neurosurgical resident, every neurosurgeon must have this image that I'm showing into his mind, because this is a 3D kind of demonstration of the veins. Anterior cerebral vein joined with the thalamostriate vein, which takes the anterior, middle, and posterior caudate veins, joined by the superior choroidal vein to form the internal cerebral vein, giving the posterior septal, giving the atrial veins. So these two will be joined with the vein of Rosenthal to form the vein of Galen. If you want to operate upon the pineal, you will be operating here. And this anatomy is very crucial. It is not a place for mediocre surgeons or for novices at all. Again, this is the venogram showing you the details that I've mentioned: anterior septal, thalamostriate, internal cerebral vein, into vein of Galen, and then into the straight sinus. So many anomalies, or let's say normal variations of how this vein of Rosenthal joined the vein of Galen and the straight sinus. You have to be familiar with these changes, and you have to make sure that you see them on the venogram, otherwise you would damage them. The point I want to make: stop reading from handbooks. It really breaks my heart to know that lots of neurosurgeons and lots of neurosurgical residents, they read from small handbooks, which just teach them to be parrots, saying what are the branches of so-and-so, 1, 2, 3, what are the branches of so-and-so, 1, 2, 3, without actually knowing the structures. So one has to read from textbook. And for me, I choose to read from Yazarjil since I was resident, and I still am reading Yazarjil. It's a beautiful book, and it's made of 6 volumes, volume 1, 2, 3A, 3B, 4A, and 4B. It's not enough. Maybe you need to read from another textbook, whatever it is, Sweet or Schmidt or whatever. I had to, and every resident and neurosurgeon must read Rotten operative book to learn the anatomy. You have to read Russell and Rubinstein pathology. You have to read the Osborne brain images and the neurological differential diagnosis of John Patton. Don't read from handbooks. I have nothing to do against Mark Greenberg. He wrote this as a note that he used to take in preparation for the exam, and then he thought of putting them into book. But I'm sure he would not be happy to know that residents and their mentors, they just take it as a textbook. This is handbook. Handbook means that something that when you buy a TV or a car, you have handbook for how to operate the car or TV. This is handbook. You put it in your pocket in your white lab. This is not a textbook. Greenberg is not a textbook. In addition to all the readings, you have to read the new developments from journals. For myself, I read these journals every month. I've been doing this for so many years, and I became advisor and on the editorial board of these beautiful journals. So, having done the anatomy of the pineal tumors, let's speak of the pineal anatomy. Let's speak about the pineal tumors. They are rare, 0.5, maximum 0.5 in adults, more in children, so it's more children pathology. And as I said, in the children, it's more malignant than benign. The kind of tumors that we'd expect in the pineal locus is either that the tumors are arising from the pineal gland itself, the material itself, or structures that surround the pineal gland would actually give you the tumor, or it is metastasis. So let's look at that. So if it is arising from the pineal gland itself, we have 4 groups: the germ cell tumor, the pineal parenchymal tumors, the glial tumors, and miscellaneous. Germ cell tumor constitute the majority, 50 to 70%. Excuse me. So the commonest tumor, if it is arising from the pineal gland itself, is germ cell tumor, followed by parenchymal tumors, followed by the others. Let's go through these. Germinoma is the commonest, and we have 2 types of tumors. We call them germ cell tumor, either germinoma or non-germinoma. So we speak about germinoma, germ cell tumor, or non-germinoma cell tumor. And these are the majority, 60 to 70%. And these include the germinoma, the teratoma with its different types, yolk sac tumor, perineal carcinoma, and choriocarcinoma. Germinomas. They respond well to chemo and radiotherapy, so much so that if you are sure that you are diagnosing germinoma, you do not need to take a biopsy, you do not need to do surgery, you just treat with radiotherapy plus minus chemotherapy. So that's the value of knowing these tumors. So this is kind of tumors that you would see. Germinomas in general, they love to go into the supracellular area and into the pineal locus. Again here, different germinoma tumors. And here the markers are important. There's the alpha-fetoprotein and beta-HCG, human chorionic gonadotropin, are positive. Then you can rest assured whether in the blood and CSF, better by both, finding positive in the blood and finding positive in CSF. But sometimes CSF sample is difficult to get, especially if you have increased intracranial pressure, you are afraid of herniation. So blood markers, alpha-fetoproteins and beta-HCG are positive, then no surgery, you go for radio chemotherapy only. The non-germinomatous germ cell tumor, as I said, that's the differentiate between the germinoma and non-germinoma. So we described the germinoma. What about the teratoma? Teratoma could be like this, tumor here. It can be a mature cystic teratoma, or it could be an immature teratoma. Again, we described the germinoma, we described the teratoma. What about the other tumors? Embryonal carcinoma, choriocarcinoma. And again here, something that I will allude to because this really irritates me a lot. When people presenting with a tumor causing hydrocephalus, the thing that they do is to do a shunt, which is to me is a criminology at its best. It is just denoting that this particular surgeon has no idea about neurosurgery. He is ill-trained and he is training ill-fated residents. This is cholangiocarcinoma. And the second group, as you said, which is the second commonest, so germinoma, non-germinoma, germinoma, and teratoma, and the others. The commonest, 70%, 60%. The second group is the tumors that are arising from the glandular tissue itself, the so-called pineal parenchymal tumors. And these are simply three types: pineocytoma grade 1, intermediate grade 2, and pineoblastoma grade 3. The commonest is the pineocytoma grade 1. So this is pineocytoma. It is the least aggressive, and it happens in the young adults. Pictures of MRI of pineocytoma. This is the intermediate type, aggressive but less than pineoblastoma. These are some of the pictures, and actually this is one of my cases. And the third type, which is the pineoblastoma, which is very malignant, and unfortunately it happens more in children. So the germinoma group, commonest, and the second group is the parenchymal tumors, pineocytoma, pineoblastoma, and the intermediate. Some of the features of the MRI of pineoblastoma. And as I said here, you use the markers in the blood and in the CSF to differentiate different types of tumors. So alpha-fetoprotein, human chorionic gonadotrophin, placental alkaline phosphatase, and melatonin is different secretion and different pathologies. So these tumor markers are good for diagnosis and they are good for follow-up of the treatment. Recently, this type of a tumor has been described and added to the parenchymal tumor, analytic primary parenchymal tumor. It's recently mentioned by the WHO classification, in the WHO classification. So some of the papers mentioned about this in new type of the tumors in the category of parenchymal tumors and the pineal gland. The third group are the tumors of the structures that are around the pineal, glial cells or ependyma or choroid plexus, etc., etc. Examples, these are only 10% of the tumors. So they can come from glial tumor, from the ependymal lining, from arachnoid cells, and from vascular cells. Pineal astrocytoma, glial, from the surrounding area, from the commissure in particular. And astrocytoma from the commissure, pineal astrocytoma, one of my patients with hair histology. And here is the oligodendroglioma. Again, this patient has been referred to me with this. And I call this disease of the Arab world, a disease of the third world countries, where people only doing shunts simply because they are not good at neurosurgery, microscopy. So you see it in craniopharyngioma, in pinealoma, in third ventricular tumors, and the fourth ventricular tumors. The first thing that they teach, first thing that the residents do is to do a shunt. Shunt is a good surgery, but it should be done very, 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 and I keep saying very rarely, not for every case, simply because the surgeon is incompetent to do the surgery. Glioblastoma in the pineal region, ependymoma, and one type of the ependymoma is the papillary type of the ependymal cells. Meningioma arising in the pineal locus area, dermoids, epidermoids. One of my patients, 36-year-old female, and this patient, again, one patient of mine with this epidermoid in the pineal region. And this is before and after surgery. Again, lymphoma can be there, and this is one paper describing from New York, describing this pineal gland lymphoma. Lymphoma actually should go into differential diagnosis of most of the intracranial pathologies. lymphoma, and this is one patient of mine coming from Kurdistan, Iraq, where the tumor is there in the pineal region. The last group, before we get to the metastasis, is the non-neoplastic tumor-like condition, something not related like arachnoid, cystosarcosis, AVM, cavernomas, aneurysm, etc. So this is arachnoid cyst, again in one of my patients. Pineal cyst. Pineal cyst we will discuss later. Pineal cavernoma in the region of the pineal, vein of Gland malformation. And the last type is the metastasis, which is very, very rare. So this is the MRIs of a metastasis from bladder carcinoma. So we know now the anatomy of the pineal. We know now what are the tumors that can arise from the pineal gland itself. We are talking about germinomas, talking about the substance itself, parenchymal. We're talking about the surrounding structures like meningiomas, others, and we're talking about cysts and cystosarcosis and cavernomas and metastases. You have to add to them these differential diagnoses. These lesions can happen in the posterior part of the midbrain infarct, hypertensive bleed, Paget disease, lupus, vasculitis, Wernicke encephalopathy, Korsakoff syndrome, osmotic demyelination, very common in children. And now we come to the presentation. How do these pineal tumors present? Mostly by raised intracranial pressure, i.e. hydrocephalus. So do not please put shunts. Eye signs is very important, 80%. Cerebellar signs, pyramidal signs, endocrine signs, etc. But the above two, the raised intracranial pressure and the eye signs are the commonest. When we speak about eye signs, we speak about Pineal syndrome, and this is Henry Pineal, a French man who discovered this and called it after his name. What is Pineal syndrome? The causes are midbrain compression at the level of the superior colliculus. This can be caused by pineal tumors, but also can be done and caused by any lesion in the midbrain, tumors, vascular lesions, multiple sclerosis, infarcts, etc. So this is just a cut of the midbrain. This is the cross cerebri, and this is the interventricular cistern, and this is the back, the superior colliculus, and this is Edinger-Westrel nucleus, this is red nucleus, this is third nerve nucleus, and this is the third nerve going this way. So any lesion in this area would cause Pineal syndrome. Sometimes it's called dorsal midbrain syndrome or pretictal syndrome. And that is composed of conjugate upward pulses. They cannot look up. And this actually explains the sunset appearance we see in hydrocephalus in babies. The same principle. Convergence nystagmus, poor light reflex because you are affecting the third nerve and Edinger-Westrel nucleus, weak accommodation reflex, sunset appearance which I described, and lead retraction. Let's see this video just to remind ourselves about the Pineal syndrome. So when asking this girl to look up, she can't. No upward, loss, palsy of upward gaze. And look at the nystagmus. Okay. See the other one? Same thing. Saccadic movement, the nystagmus.
The video is not showing.
Oh, the video is not showing. Okay. What about now? Is the video showing?
Yes.
Yeah, it's fine. It's showing.
Okay.
Yes, yes.
So again, you can see the saccadic movements, and when this patient is asked to look up, there is palsy of upward gaze. So pulse of upward gaze weak direct right reflex, weak accommodation, and this is Pineal syndrome. Okay. So we'll come to the treatment. I have put to you the algorithm of the treatment that is accepted by everybody dealing with these tumors. For the initial diagnostic evaluation, you have to do brain MRI, spine MRI to know whether you have droplet metastasis or not, and then you do your tumor markers. Alpha-fetoprotein, mainly beta-HCG, the others if you have them, alkaline phosphatase and melatonin. Then, once you do that, you have the MRI, then you have hydrocephalus or you don't. If you have hydrocephalus, there are so many options here. But the option that everybody goes to is to put a shunt. This is not on. This is really not on, unless you are living in the desert, in a place where there is no medical facilities. You can always do third ventriculostomy. You can always put external drain. You can always do anything, but don't put permanent shunt, especially for a child. This is disastrous. And then you do the tumor markers, the alpha-fetoprotein and beta-HCG. Are they positive? This confirms the germinoma type. Just go for radiotherapy, chemotherapy, no surgery. If the markers are negative, then you have surgery to do, and according to the surgery, you behave and give the patient the adjuvant treatment accordingly. So true germinomas are radio-chemosensitive, and they have the best survival. So if you are in doubt and you have to take stereotactic biopsy, this is just to make sure that this is a pure germinoma. So this is a huge germinoma, and just with radiotherapy, it disappeared. So here's a good example of how to use radiotherapy. Not the across the board treating anything and everything with radiation. This is not on. This is another crime that is being practiced every day around the world. Pineal parenchymal tumors, surgery, and followed by radiotherapy. They have the worst survival, as we said. Look at this. In the past, 1960s, that's what the people used to do. They used to put a shunt and send patients to radiotherapy. This is 2020. 60 years later, we are still doing what our ancestors have been doing. Stop putting shunts and send patients for radiotherapy, for goodness grace, please. So this is hydrocephalus of these patients. And I call this, and I insist, this is the Arab world disease. This is a third world country disease where everything and anything is treated with a shunt. And when you ask a resident, how many operations have you done? He would tell you, oh, I have done 300 surgeries. What are they? 299 shunt, revision of upper end of the shunt, revision of lower end of the shunt, treatment of meningitis, and so on and so forth. You would not, I would not accept to put a shunt in the head of my boy or girl. Please don't put shunts. Not only this, but the shunts are even done in the wrong fashion. I mean, even these people, they are not trained of the direction and where to put the shunt. The shunt should be directed into the trigone, into the occipital horn, the trigone. This is the largest area of the ventricle, and it should not go anterior so that you will not go through motor area. It should not go to the posterior occipital horn or this transverse or this. So these are not only that it is not indicated, but it is badly done because these people, these residents have been taught badly by bad mentors. So when you have CSF problem, you can also do the external drain, the ventriculostomy. The shunt, in addition to all what I mentioned, make your surgery difficult. If you are going through the endoscopy or you are going through the ventricle, you'll have difficulty. Now you want to do surgery, as I said, you have to approach different approaches for the pineal gland, but mainly you can classify them into above the tent or below the tent. So this is the picture, this is the straight sinus, the transverse sinus, the sigmoid sinus. So you can go above, this is supratentorial, or go below infratentorial. You go in the midline or paramidline or far lateral. So it all depends on the tumor, the size of the tumor, and is it above or below the tent. And you have to know the anatomy, as I said, of the venous system. You should know them by heart, not from Greenberg, that the internal cerebral vein drain the following veins. This is not good. So here is the supracerebellar going to the tumor. And this is here, infratentorial, supracerebellar, or supratentorial. One kind of thing is this kind of approach, the supratentorial approach, where you retract the occipital lobe. So here you are on the right side, temporal. Luckily here we don't have much of draining veins, so you can retract easily, but you have to be careful about the visual area 17, 18, 19. So this is the tent, this is the straight sinus. You can actually cut the tent this way, about 1 centimeter parallel to the straight sinus. Here you are. You want to reach to the pineal, but also you want to see the anatomy here. So that's the anatomy is being hidden, and this is the tent, this is the straight sinus. So you open the straight sinus like this, the interium like this. Here's the scissor cutting this way, and then you have the whole area in front of you. You can see all the drainage veins there, and then reach to the pineal gland. Here you can see it here, lower down into the velum, superior medullary velum, and you can see both branches of the posterior occipital artery and superior cerebellar artery. So this is the approach, the supratentorial approach by splitting of the tentorium. You can see the internal cerebral veins, and then they're joined by vein of Rosenthal and the internal occipital vein. The other approach is the retrosigmoid, and I do this in the sitting position using the monitoring of the cranial nerves and the navigation if necessary, emphasizing that the navigator is your brain, not the machine. The machine is just to give assurance to you, it's just to teach your residents. But if you differ with the findings with the navigation machine, kick it with your foot and just continue with the navigation of your brain. So semi-sitting position that we have been doing for decades. Of course, you can do it to the park bench position. I've tried it. I like the sitting position. And as I said, it has so many advantages that you can actually operate easily. You don't need assistant. The blood and CSF will just flow by gravity. So once you open the craniotomy, this is what you see. And you have to be careful about these draining veins here. They are important. You don't cut them. You just make sure that you find a space between the draining veins to go. This is the tentorial surface of the cerebellum. This is the squamous or occipital surface of the cerebellum, and here is the petrous surface. So this is the kind of thing that you may face. So don't go and cut these. You go either in this window here or this window here. Of course, going in the midline is easier because you will go directly to the pineal gland. But with this arrangement, you have to go to one side. So all these veins draining into the tentorial sinuses are important. And here we are seeing the inferior vermian vein. So you look at the arrangements of the veins and then you decide. If you can go in the midline, go in the midline. If you can't, you have to go laterally. Usually it's, you'll find a window there. So little by little, you go and you see the draining veins, preserving them. Venous system is as important as the arterial system, but unfortunately, this has not been taught to our residents because their mentors are not good at it. If they are good at teaching, they should have taught them all about the venous drainage. So when you come to the pineal region, this is the arrangement. You are actually below. Here is the vein of Gland, and you can see the basilar vein of Rosenthal. These are the internal cerebral veins, and this is the superior Permian vein. So this is the pineal. And this area is covered with very thick arachnoid membranes. The thickest arachnoid in your body is there, unfortunately. Again, this is the arrangement that you are going to see. You have to be familiar with the anatomy. You will not damage any vein because every vein counts. Knowing the anatomy makes your life easier. It makes your patient's life easier. You can actually use both the supratentorial and infratentorial combined if there is a good need for that. The one person I know who has done the largest number of pineal tumors is Alexander Konovalov from Bordenko Institute in Moscow, Russia. And this period of time, 76 to 99, he operated in 287 patients. I met with him recently. His number now goes up to about 600 patients. Alexander Konovalov from Moscow. Of course, you can use endoscopy, but just doing the usual endoscopy, you go through foramen of Monroe, and then redirect yourself to the posterior part of the third ventricle. These are the beautiful pictures of endoscopy from cadavers. I repeat and always say that endoscopy carries the future of neurosurgery. Look at this beautiful picture showing you this adhesion. This is vein of Gland, but it is covered with thickest membrane you can ever lay your eyes on. It's very thick, and you have to do it with scissor or knife. It's not enough to just bluntly dissect. It has to be sharp dissection, and with sharp dissection, if you don't know the anatomy, you will cause damage to vein of Gland and death on table. What about radiotherapy? You can, as I said, it's a good tool. You give whole brain radiation, you give a tumor boost radiation, you have the neuroaxis radiation. For me, it should be administered to all patients with pineal region tumors, except cysts, meningiomas, epidermoids. As I always keep saying that we have acquired the gamma knife back in 1996. When I speak about gamma knife, about radiation, I'm in a position of power, in a position of knowledge. And when I criticize it not because it's a bad machine, it's because of the bad people who are using the gamma knife. They are using it for anything and everything simply because they are not good neurosurgeons. So this is radiotherapy that we advocate for most of the patients with pineal tumors if the need is there. Chemotherapy also is useful adjuvant cisplatin for germ cell tumor. What about survival? Pure germinomas have the best survival. 5 years, 95%. 10 years, 88%. Look at the malignant germinomas, 20% 5 years and 0% at 10 years. Now to my series between 85 and 2017, I had 61 patients. I was lucky really to have this large number of patients, but I could only maintain follow-up of 48 patients, and these are the ones I'm presenting. Male to female was 3:1. The MRI pictures of my patients, you can see them, and most of the time the lesions are giant. As in this part of the world with the lack of health knowledge, people would just wait and wait and wait until things get really to a giant size like this. They are challenging, but they are interesting. So this is the MRI of these patients that I mentioned to you. CT scan, you can see that you can see calcification in the pineal, the normal physiological calcification in the pineal, and sometimes you'll find calcification in a tumor. So you have to differentiate between normal calcification and abnormal calcification. So this is normal pineal gland with calcification, and this is abnormal calcification. Vessels, look at the vessels in the MRI, you can see the relationship of the tumor with the vessels. Look at here, you can see the internal cerebral vein on the upper surface of the tumor. You can see it here, deviated. You can see it here, the same, deviated. So you look at these tumors and the relationship with the vessels, and you would learn how to do your surgery. Look at here how the vein of Gland and the internal cerebral veins are pushed. Here they are inside the tumor, and so on and so forth. And I'm showing you these MRIs, and these are my patients. MRA, MRB are very, very valuable. You have to know exactly what you are dealing with and where every vein is in relation to the tumor. Coming to the pineal cysts, this is usually some patients are referred to me for surgery. You don't need to operate on pineal cyst unless necessary, and I will tell you how. This is the normal pineal size, and this is the pineal cyst. Some of the cysts that I receive as pineal tumors, but you don't need to really operate upon them. This particular one is from Ann Osborne book, which I keep going back and read from. So pineal cysts. You can get pineal apoplexy, bleeding into the pineal cyst. This is a very beautiful paper by Serene in the Neurosurgery 2016. 232 patients, 56% had cysts. Imagine, half of these patients had cysts, but they are normal. You can have single cyst, you can have multi-cyst, you can have many more cyst changes. If you follow them up, and I advocate that you follow them up for all the cysts, you will find that 50% will be stable, only 40% will increase, 10% will decrease. And for the increase in size, you have the option of whether to operate or not. This is again from Ann Osborne, whether the calcification is on the side or it is surrounding the lesion, to differentiate between the pineocytoma or a pineal cyst. So pineocytoma is a cyst with the rim of calcification. Some of the illustrative cases of mine, this 27-year-old female patient with epidermoid tumor in the region of the pineal, and I call them tumors, not cysts, because the whole world, all the neurosurgeons, all the pathologists stop using the term cyst. The epidermoids are not cysts, they are tumors. Go back to original paper by Yazarjil back in 83 or 84. And here you can see that this is an epidermoid. And this is after surgery. No shunts, no misery of shunts. There's no need for. And this is the immunohistochemistry that we used in these patients. Other patients with an extensive 43-year-old male patient with extensive epidermoid in the region of the pineal before surgery and after surgery in the lower row, and the patient doing well. And this is his follow-up. Another one, male patient, 41-year-old, much more extensive epidermoid, pre and post-op. And to me, the only time that you can see a pineal is when you operate on such cases of epidermoid tumors, because the pineal gland is still intact. It's not destroyed by the tumor. In most of the cases, you don't see a pineal gland, you see a tumor that you remove. But here, if you take the epidermoid, you will see the normal anatomy of the pineal gland with its two crosses, one cross on one side and the other on the other side. Arachnoid cyst, and this 73-year-old female Jordanian patient. Again, she presented with hydrocephalus. So the easiest thing is to put a shunt, crime against humanity. And this is after excision, drainage of the cyst, and here in the lower row showing the follow-up. This young patient, a 19-year-old with this tumor in the region of the pineal, it turns out to be a pilocytic astrocytoma. And this is her post-operative pictures. And this patient from Bahrain with this lipoma sitting on the tectal plate, quadrigeminal system, quadrigeminal plates, and you can see that he's tilting his head because of the fourth nerve palsy. And these are some of the still pictures. This is infratentorial supracerebellar, and you can see here, you can see the veins and the tumor and the lipoma to be dissected. This is the fourth nerve coming from the back of the midbrain, and this is the tumor here. Now have liberated the fourth nerve patient as well, and his upward gaze is improved. And this patient also Jordanian, 37, with this meningioma of the pineal locus. This is before surgery. This is after surgery and follow-up. The last case that we are reporting here with a video, so that we'll conclude with that, and I will give the stage to my daughter, Dr. Asil Sbeh.
Hello everyone from beautiful Amman. I'm Asil Sbeh. I'm a neurosurgical trainee at the Royal Medical Services here in Amman, Jordan, and I will be presenting today's case. Our patient is a 37-year-old male patient. He came from Bahrain, and he had a significant history of 3-month duration of headache, decreased visual acuity, and diplopia. It's worth mentioning that decreased visual acuity is a broad and vague complaint, and it should be thoroughly investigated to see what the patient is actually describing. He also complained of amnesia and urinary incontinence, in addition to right upper limb weakness. His vital signs on examination were okay. Chest, heart, and abdomen were fine. Glasgow Coma Scale 15 out of 15, although he had a speech impediment and he was dysarthric. And this could be actually explained by increased intracranial pressure. He also had a third and fourth cranial nerve partial palsy, which you will see. And as I said, he had urinary incontinence of urge component, and there's many types of incontinence that should be investigated also thoroughly, as each one would indicate the location of the problem. He had impaired upward gaze, which is expected in a pineal gland tumor, and he had decreased visual acuity, and he had the famous retractorious nystagmus, in which is seen in the pineal gland tumors. And this kind of nystagmus is actually described by a slow component while abducting the eyes and a fast component on adduction. Cerebellar signs were intact, but he had an ataxic gait, which can be explained by the hydrocephalus. He had right upper limb weakness, as we said, he had a 4+ out of 5, with no hyperreflexia, but he had hyperreflexia bilaterally in his lower limbs. ECG and chest X-ray were okay. He had normal preoperative lab investigations, except for mildly elevated liver function tests were okay and didn't need any further investigations. Pre-op imaging, this is the MRI T1 without contrast. We can appreciate the very apparent hydrocephalus, dilated third ventricles, and third ventricle and the lateral ventricles, and this is our lesion right here. This is with contrast. We can see heterogeneous enhancement, especially here in the center. More cuts denoting the impressive hydrocephalus, and here we can see the temporal horns of the lateral ventricles, which we don't normally see. And the lesion is actually compressing the aqueduct, which is encouraging more hydrocephalus. More images showing our lesion and the hydrocephalus, and as we said, MRA and MRV is a basic investigation when it comes to our patients. The MRV is particularly important to appreciate the internal cerebral veins and the relationship of the tumor with the vein of Gland. The MRA was normal except for the bowing of the anterior cerebral arteries, which is seen in hydrocephalus. more cuts so we can appreciate the tumor. And here we can see the tumor resting on the tectile plate and actually flattening it. Beta HCG and alpha-fetoprotein were sent, and they were normal. Consultations, we usually consult our psychiatry for KPS, Karnofsky Performance Scale, as it can assess in the prognosis of the patient and actually can decide if we can go further on with the surgery or not. The ophthalmology, obviously, for the visual acuity and the nystagmus, and they confirm the impaired lateral and upward gaze palsy. There's the visual field for the patient. You can see non-specific decreased visual acuity in the right and left eyes.